Welcome back from lunch, everyone. Thank you for joining us in this last afternoon of conference. We're really happy to have you here. This next session, we're going to talk a little bit about a new take on the ins and outs. So I'm going to just quickly hand things over to Dr. Kent Williams, who is a gastroenterologist at Nationwide Children's Hospital, and he's going to guide us through this next session.
Thanks, everybody. Well, hello. Again, they made the mistake of making this conference right after lunch, so hopefully we won't have too much about poop and pee and everything that will nauseate you. But I've been fortunate to be part with PPMD. They're putting together a group of people to actually make further recommendations that are very much needed to help with just basically trying to give more support and information to people about nutrition, about your daily routines, and things that most people just don't think about until they have a problem. So, Kiera, are you first? Okay, Kiera Berggren. Yay. I'm terrible at names. But Kiera Berggren is at Virginia Commonwealth, and she is part of the team with me, for who I'm doing GI. She is helping with speech and nutrition and swallowing. So, Kiera, why don't you come and give us a talk?
Good afternoon. I love it that the speech-language pathologist is always either before lunch or after lunch when all the eating is happening. So I'm Kiera Berggren. I'm a speech-language pathologist at VCU, as Dr. Williams mentioned, and I'm going to talk with you briefly about the ins part of the ins and out of Duchenne, specifically swallowing function. So first, what about swallowing? What is dysphagia or swallowing difficulties? This is kind of our little agenda for the brief period. I'm going to hopefully share with you some tips of what to look for and then next steps if somebody has some swallowing difficulty. And I'm super informal. I know we're going to have a Q&A afterwards, but if you catch me in the halls as well, I'm happy to answer any questions. So swallowing concerns or dysphagia, really these can happen kind of all throughout the system. I think most of us naively think that swallowing is just this part of it, but as an SLP, I think of it as from when food gets in the mouth to when it gets down into the stomach, and then I pass it off to the GI folks after that. So this can happen really at any time. It tends to, in the dystrophinopathies, be a little bit later in life, but it can be earlier, depending on the individual. And it's in the literature, they say about a third of individuals with Duchenne or any of the other Duchenne-related diagnoses may have dysphagia problems, but in reality, I think that value is actually probably a little bit higher than what the literature is saying so far. Some of that data is a little bit older. So I apologize, this slide looks like it's showing up a little bit small, but these are kind of some common signs of somebody that may have some dysphagia difficulties. And we pushed out a survey back in the fall. Thank you for those that maybe have participated in that survey that was targeting care partners, caregivers, and tipping people off to maybe some common signs of dysphagia. And our survey results we got back in sort of preliminary work as we're trying to update care considerations around this indicated that some of these things weren't really well known, or were kind of surprising for families. So I wanted to kind of highlight some of them. So some individuals, if they used to eat X, Y, or Z food, and all of a sudden they kind of stop eating it. The ones I normally hear about are things like steak or popcorn or things like that may be a little bit more challenging. So those can be some kind of subtle signs that maybe stuff is going on. If somebody's complaining food's getting stuck somewhere, often they'll complain here, sometimes in the esophagus. If meal times are starting to take longer than about 20 minutes or so is kind of ballpark in our country. If they're stressful, this was one that popped up on our survey. If mealtimes become stressful for either the person with the diagnosis or their care partner, or if they're really kind of more of a picky eater. So you're, giving everybody the same plate of food at the dinner table, and they're picking out little bits of it and ignoring other parts. That can be a sign of that maybe there's some swallowing difficulties or some difficulty with eating. A big one that I think a lot of us look for in the clinic side of things is unintended weight loss. So if all of a sudden weight is kind of dropping off on somebody, we want to make sure that they're, from a function standpoint, able to get the calories in. Coughing, choking during meals, or difficulty with food staying or liquid staying in the mouth are also kind of some signs of dysphagia. And I do like to qualify that these kind of can happen to everybody, every now and again. But when they become more frequent, or you're the most frequent one at the dinner table that's evidencing some of these signs, then that's kind of oh gosh, I should pay attention to this. So I think I wanted to kind of highlight why this is of concern, I think, for those of us that work in care centers for Duchenne in particular, is in my head when I see a new individual or individuals I've seen for a while, I'm immediately thinking, what are some factors that can go into swallowing problems? And does the person I'm working with have any of these? So certainly the diagnosis is an area of concern. Age, ambulatory status. Are they moving around a bunch under their own power? Are they wheelchair bound at that point? Are they able to feed themselves? Kind of a hidden one is that pulmonary function piece. So I'm thinking about what those respiratory numbers are as well too for individuals, because coughing and breathing and swallowing are kind of pretty intimately related. And then obviously their swallowing function itself. And all of these kind of go together to kind of lead towards concerns for elevated risk of developing pneumonia, which can make us quite sick, and really would like to avoid that as much as possible. So if we have somebody that has dysphagia problems, where to go next? I think one of the things that was surprising to me that popped up in the survey is there were several questions where people said, gosh, I didn't even know this was an area of concern for swallowing or in Duchenne or Becker. And gosh, where do we go from here? So if they're happening more frequently than average, talk to your physician. And that can be your pediatrician. That can be, if you're in a neuromuscular clinic or a PPMD care center, the neuromuscular doc. It can be the rehab physician. You can certainly talk with the pulmonologist, like the GI physician. There's a bunch of us on the team for those that are seen in some of these multidisciplinary care centers that you can bring this up with, and they'll happily kind of help out. And I really would encourage people, this was another thing that popped up in this survey, is, gosh, where do we go after that? You can ask for a referral from any of these physicians to a speech-language pathologist, even though swallowing isn't in our title officially. It's one of our main areas of focus. And so we can help assess function, look at risk, all of that. And then I work really hand in hand with dietitian in our clinic, both on the pediatric and adult side of things. And we really kind of come together as a really nice team in terms of making sure that from a function standpoint, and you'll hear from a colleague of mine as well here, Grace Gough, the dietitian, the nutrition side of things, to have people be able to eat safely and nutritiously. We're not going to tell you don't eat X, Y, or Z. We're going to brainstorm with you, how can we get calories in? How can we have eating be as normal as possible? So please, please, please consult with us. Some kind of general tips are keeping meals a little bit shorter. So fatigue, what I hear a lot about in Duchenne in particular is jaw fatigue with chewing. So keeping those meals a little bit shorter. We would all probably do better with smaller bites and sips. I don't know about you guys. A salad for lunch was lovely, and I was like, okay, shoveling it in between things. Taking time while you're eating is really helpful. Considering some strategic things like a nosy cup. It's a little cup that makes it a little easier to drink without having to tilt your head way back, or maybe using a straw if that works for you. Being upright, and I work with my PT colleagues to make sure we have good trunk support if that's a concern, or if scoliosis is a concern, or things like that. And maybe modifying the diet ever so slightly to have softer, more moist foods, especially later in the day when we're all a little more tuckered out. Maybe not the time to have nachos, even though that would be amazing for every meal. And so think about, something like a meatloaf is going to be easier than a steak to eat. A casserole, a crock pot type dish is going to be a little bit easier and feel a little bit more comfortable, is what I hear a lot of times from my patients. So take-home message really is consulting with speech and dietitian. Ideally, every 6 months would be really nice. Sometimes for me, often in clinic, it's actually just a touch base. Hey, how are things going? Are you avoiding any new foods? Are you having any difficulties? Things like that. If they tell me lima beans, I'm a little less suspect of swallowing difficulties. But if they tell me the fun foods, then like chocolate cake or something like that, then I'm going to get a little more concerned. And I think as dinner partners or meal partners, being mindful of any changes in eating habits, things that you start to see that you're like, they didn't used to do that a year or two ago, I think is a really good thing. So, and we will take questions later, but keep us on track here. Thank you so much.
All right, next we have Grace Gough, who, no, I'm sorry, Dan, are you next? Grace, sorry. I should look ahead of time, my apologies. Grace is next. She comes from the University of Utah. She is our dietitian. I always have patients ask me in the clinic, what diet should my patient be on? I have to explain to them what the letters at the end of our names mean. MD means medical dummy, and RD means recommended diet. So please, Grace.
Thank you. So happy to be here today. My name is Grace Gough. I'm at the University of Utah. We have a sister clinic at Primary Children's Hospital, and I've been there for like 8 or 9 years working with patients with Duchenne. So today, and I'm going to work really hard to stay on track, I promise, we're going to go over some basic nutrition recommendations, focusing on some specific micro and macronutrients, to make sure that we're just covering some of those general basics. We're going to talk for a second about weight management because that is a consistent concern with the families that I work with. And we're going to finish with how what we're eating is affecting our bowel health overall. So in general, the nutrition recommendations consistently encourage eating with a MyPlate recommendation, which isn't a huge, shocking change for a lot of families, but what it tends to do is it decreases the amount of starches and grains that we typically eat and encourages more fruits and vegetables. The MyPlate can be applied on a small scale as an actual meal, or it can be sort of extrapolated to what you're eating over the full course of the day, where we want half of what we're eating to be coming from fruits and vegetables. Still that 25% from our grains and starches, and then 25% from our protein, adding in that dairy piece as well. And a huge part of doing this is that it makes it so that it's modifiable while still working for an entire family. So if you need to decrease the amount of fruits and vegetables slightly because you have an eater in your household that doesn't love those particular types of foods, you can still all be eating the same things while adjusting slightly how much of all of those things you're eating. So it tends to work really well in a family setting. We want to make sure that we're not singling out any particular member of our family and imposing any specific dietary recommendations just on one person while everybody else can eat freely. That what we're doing is, as a family approach, adopting the same dietary patterns, habits, and foods for everybody. What we like to see and what I encourage for pretty much any family that I work with and any patient that I work with is increasing fruits and vegetables. We just don't eat enough. And there's a lot of barriers to fruits and vegetables. People hate watching them rot in their fridge and then literally feel like they're throwing away their money. Or they, it's a consistent battle with their children. They see one tiny piece of green broccoli on the kid's plate and the kid goes ballistic and the meal is derailed. So I know that there are barriers to this, but there are approaches that can make it a little bit more accessible, and I would encourage everybody to start small. So we want to be really basic, one serving of a fruit or a vegetable at each meal, and it's not that much. Half a cup of a cooked vegetable is like 2 pieces of broccoli, maybe 3 depending on the size, or a cup of raw. It really is less than what it feels like and what it may seem like. So getting something at every meal establishes that habit. And then from there, we can work on improving how much we're getting at each of our meals. It takes a certain number of exposures to foods in order for them to be accepted. So don't give up. Most parents give up after 5 tries. In a neurotypical child, usually 8 exposures is how many it takes to adopt a brand new food or to decide whether or not they like it or don't like it. In a neurodivergent child, it can be way more than 20 exposures before they know for sure how they feel about a certain food or if they're going to be able to adopt it. That's, if you give your child a cauliflower once a week, that's nearly half a year that you'll have to spend presenting that food, encouraging them to try it, even leaving it on their plate in some cases. So starting really small and working toward bigger goals is the way to go in this case. And we want to eat with color. I love it when I sit down with a patient and say, hey, are you eating fruits and vegetables? Tell me what you are. Oh, I have something at every meal. What is it? An apple. They eat an apple at every meal. Are they getting servings of fruits and vegetables at each meal? Yes. But is it the same one? Yes. Are we getting the same benefits from that? No. So we want to encourage as much color on our plates as we possibly can. I get a lot of questions in a neuromuscular clinic about protein because the relationship between protein intake and our muscle health is well known and established. So what do we want to do for our kids? Do we need to be giving them copious amounts of protein? No. The research indicates somewhere in this 1 to 1.5 grams of protein per kilogram of body weight, and a kilogram is about half of a pound. So you take a child's weight, you divide it in half. We want to be about in that range as far as protein goes to make sure that we are keeping muscles as healthy as we possibly can. We do not need to overload anybody with protein. It's not going to make anything better, but not having enough protein is also not beneficial. So making sure we're getting enough. And it doesn't have to be meat, especially in the case of swallowing difficulties, as Kiera so beautifully touched on. We can do eggs, we can do ground meats, we can get a ton of protein from cottage cheese, we can get it from yogurts, things like that. But we have to be aware of how much protein we're getting from each one of those foods. Not all protein-containing foods are equal. To get a little bit more specific now, moving from our macronutrients to our micronutrients, we want to focus primarily with our Duchenne kids, making sure they're getting the calcium and vitamin D that they need each day. And this is really important for keeping their bones healthy. So calcium goals are going to be 1,200 to 1,500 milligrams when on steroids, and 1,000 to 1,300 without steroids, depending on the age of the child. This can sometimes be more difficult to get than it looks like, depending on how much dairy product the child is getting in their diet. So keeping track of that, taking a little bit of time to track maybe and just figure out exactly how much calcium they're getting, and then supplementing if needed. Calcium supplements and vitamin D supplements are easy. They are pretty well accepted by most kids. You can get some that taste like Tootsie Rolls or whatever to help kind of bring those up. And then we can make sure that we're getting vitamin D tested at your regular appointments so that we know how we're doing from a vitamin D standpoint. But double checking on both of those things can be really important for keeping bones healthy, and staying really proactive on it is by far the best way to go. I get questions all the time on weight management. I think it's my #1 question that I get is, the parents come in and I'm concerned about my child's weight. Whether that's an underweight or an overweight situation, we tend to get both. Weight management in this population is genuinely a moving target. Not only is it difficult to just at any one time sort of pinpoint exactly how much calories and nutrients we should be getting, but it changes over the course of the lifespan. And so finding what that exactly is, like I said, it's difficult. So there are a bunch of different ways that we can calculate one's caloric needs. And I would highly recommend working closely with your dietitian in order to do that. We have some standardized equations that we sometimes use. I know of clinics that are using something called indirect calorimetry, which will directly measure your child's specific calorie expenditure, which can be great. And sometimes we just we'll give our best guess, an estimate, that often tends to be 80% of what our typical age-matched peers consume. So that's a pretty well-established range as sort of a general spot. I would say in most cases, we avoid specific caloric numbers for children, teens, and families. So if your dietitian is giving you a specific calorie goal, there's probably a really good reason. Otherwise, we're gonna keep things fairly general, especially the younger our kiddos get, the more general we're gonna be. We're gonna focus on getting the right nutrients, making sure we're supporting healthy growth and development, and not get so specific about the numbers. But if there is a problem or a real question, then sometimes we have to get a little bit more specific. But in general, we try to avoid it if possible. I do get questions about GLP-1s at this point because there are some on the market that are being cleared for younger and younger aged populations. It's still being studied. It's not something that we really know the full relationship of muscle health in the setting of GLP-1s, so it's not something that we necessarily are recommending all the time. However, there are a lot of clinics now that are starting trials and studies to kind of look at the relationship there. So, like I said, meeting those calorie goals, work with your dietitian if that's something that's interesting to you. For keeping bowels healthy, we've already talked about fruits and vegetables. Fiber is so important, and it's from what we can put into our bodies to help with it is water and fiber. So getting those fruits and vegetables can be super helpful, changing our grains from simple to complex, adding things like brown rice instead of white, brown bread instead of white, getting pastas that have increased fiber are all good strategies. And then sometimes we just have to use pharmacological interventions. We have to use stool softeners and laxatives, and that's okay too. If you don't have water in your body, those things don't work. It's like turning your sprinklers on several times a day, but they're not connected to the water supply. So nothing is actually going to happen. So making sure that we're getting the amount of water that we need is really important. We generally, dietitians will recommend an ounce per pound, but that kind of tops out at 100 ounces, which is an incredible amount of water and not something that we usually see. But if you can get 1 to 2 liters in your kiddo and then judge it based on the color of their urine, that's generally gonna be enough that's going to help these laxatives and stool softeners do their job. I'm out of time. So quickly, overall, our patients in DMD are like a constellation. They are a host of different stars, different factors that are important, different things to consider, and that we want to overall have the same goals of preserving lean muscle as much as we possibly can through adequate caloric intake and protein, maintaining a desirable weight, ensuring adequate diet composition, keeping our bones strong, and helping to prevent bowel dysregulation. Thank you.
Thanks, Grace. Next, we have Dan Wood from University of Colorado, a urologist who I've had the pleasure of working with on the committee also. So, Dan.
Good afternoon. I'm not from around here. I originally worked for about 13 years as an attending in London in the United Kingdom, and then about 4 years ago moved to Colorado. I'm a urologist. How many people in the room have met a urologist? Okay, some. Now you can say you all have. I like the title that I was given for this talk, The Surprising Role of Urology. Many of you may never need to meet me, but it's important. I do mostly out. Some of my colleagues that have spoken do mostly in. I'm mostly out. And so what we're about is trying to make sure that you're able to empty your bladder completely, that you're keeping dry, and that you're able to do the things that you want to do socially. Obviously, the waterfall is an illustration of out as far as urology is concerned. But our neighbors are important. The bowel is really important. Your pelvic ring, the bone that surrounds your bowel and your urethra, is about that big. If you've got a big lump of poop in there, then you can't empty your bladder. So understanding that when we come to think about that is also really important. So urologists may drift and ask about our neighbors, your poops, and making sure that all is well in that regard too. What we want to do when we meet our patients is think about quality of life. We want to make sure that our patients are independent, that they can be dry, and we want to avoid complications for them as far as urology is concerned. So things like urinary tract infections or stones that you may develop if you're not emptying your bladder well are important. And of course, we want to make sure that your kidneys are healthy and avoid back pressure to those too. So when we come to think about the urinary tract, we may ask about questions like incontinence. Are you wet? We may ask you about whether you feel like you're emptying your bladder properly. We may even measure how well you're emptying your bladder properly. And if you're not emptying your bladder properly, then your working bladder volume, which should be that, may be that. And so you may be going to the toilet more frequently than you might like or than we might expect. So that's why we ask you questions like that. If you're not emptying your bladder well enough, then it's a fantastic place for bacteria to grow and multiply. And so you'll get urinary tract infections. So we think about those. And stasis, or not emptying your bladder completely, increases your risk of things like stones. So all of these things on the slides that you can see are things that we'll ask you about, things that we'll want to develop as part of that conversation. These are some of the data that we got from that survey that was mentioned earlier, and it's a little bit small, but you can see as part of that, we're seeing a growing number of people coming to see us about urology concerns. And so you may be asked in your clinic, just generally about urology problems. If you're noticing things that are different, tell the people that are looking after you. We will be delighted to see you and work through those with you from a urology point of view. When you look at the data that are out there, and there aren't many data for us to learn about this, and so we're relatively new to the table. It's a real honor and a privilege to be invited to come and talk to you all, but I'm a newcomer because people are just starting to recognize this. And so if you start to see things, then some of the survey data or information that we have out there are about a feeling of incomplete emptying, strange sensations in your bladder, feeling like you have to strain to void, and recurrent infections, which I've mentioned a couple of times. So we see around 50% of people with some form of urology diagnosis. That's really important. So 1 in 2, half of people affected are likely to want to come and see me at some point, or one of my colleagues. And so never be afraid to ask about those questions. People are often shy because they think it's going to be somewhat embarrassing. That's what we're here for. We're here to think about those symptoms and to work through those with you. So we're bit part players in this whole scenario. Many people in the room will know way, way, way more about dystrophinopathies than I ever will. And so it's truly a privilege for us to contribute to that conversation and be part of it. But we're just part of it. So thinking about us, or the way we think about it, is that we're dealing with symptoms that are secondary to a much bigger and more complex condition. But what we want to do is avoid some of those complications that I was talking about and help you go on to live a very happy, healthy life with great quality of life. When we think about whether we're going to intervene or not, the whole picture becomes very important. So for instance, if you're facing respiratory challenges, then our abilities to give general anesthetics, for instance, may be limited. So that's, again, a reason why we might ask you about things like that when you come to see us in clinic. So this kind of breaks down the urology mind. It's a remarkably simple thing with 6 boxes inside here. And what we're thinking about are those 5 areas that I was talking about earlier, from incontinence through to stones. And so we think about, are you emptying your bladder? If you're incontinent, is it because there's some form of muscle weakness from the muscles that keep you dry? Or is it simply that your bladder is overfull and this is a safety mechanism by which you're able to empty it, so-called overflow? Is the bladder firing off in an uncontrolled way, what we call DO, or detrusor overactivity? And what are the muscles, the sphincters, like in terms of keeping you dry? Do we need to think about devices like catheters to help you with keeping you empty and avoiding some of the complications? And obviously, there's a trade-off between intervention and complications versus condition and complications, and we've got to try and work through that balance with you. And if you're less mobile, then you have a tendency to excrete more calcium, and that can further increase your risk of things like stones. So all of those things start to play into what we're learning and developing as part of urology. Young adults normally think about sex and sexual function. And that's one of the conversations that, as urologists, we're very used to having. And so if you come through our door and you have questions about that, then ask us. We're really happy to think about those conversations with you. In our clinic, we've just stolen a great idea. My nurse practitioner has just done it. And actually, all of our new patients that come into our young adults clinic are going to be given a golden ticket. And what that ticket is for is so that you don't have to ask a question. I don't have to initiate a conversation that might feel awkward to you. If you've got something private or intimate that you want to talk to us about, you just hand the golden ticket to one of our team, and that tells us that you want to have some private time with your provider just to think about things that might be important or private to you, whatever those may be. These are some of the things that, as urologists, we do to people to help try and understand their condition. And I'm not going to go through it all, but we do think a lot about fluid intake. Grace was talking about that. And as urologists, we like urine to look like a fine Pinot Grigio, so very pale yellow. And that helps us to give you a guide as to how much you should be drinking. I live at altitude. I live in Denver, Colorado, so we're a mile high. And so you need to drink a little bit more to keep your urine. If it's really hot and sunny like it is outside here, you need to drink a little bit more. But around 2 liters, 60 to 70 ounces is what we would target as a good intake from a urology point of view. We work hard to keep you emptying your bladder well. We don't like leaving catheters in people, but if we have to do that, then that's an option that we may talk to you about. But there are other things. There are medications out there that we can use to help with managing your bladder over time. So all of these are discussions that we might have with you in terms of trying to look after you and keep you on the right road as far as urology is concerned. I'm really happy to answer other questions as we get to the Q&A. But you're independent people, and we want to maintain that for you. We don't want to leave you in a situation where you have to rely more than you should on anybody else. So we'll talk to you about that, and we'll try and keep that for you. It's an individual discussion. There are no right or wrong answers as far as the urology side of things are concerned. What we want to do is keep you safe and individualize your treatment plan. We don't want to forget about other aspects of your life. So if you have questions about intimate relationships, about testosterone, about sexual function, then we're used to having those conversations, and we're happy to have them with you. And what we're really trying to do is to avoid the impact of complications or things that might affect your quality of life adversely. I'm really grateful to be here. Rachel, thank you very much for inviting me, and enjoy the rest of your meeting. Thank you.
Right. Okay, now we get to the fun part, the Q&A. You've got our panel, you heard their talks, plus I'm a GI doctor. I've given talks multiple times at the conference, so if you have any questions about constipation, assistance with stooling and feeds, please feel free. Yes, go ahead.
Hi, I'm Lisa. I actually have a question for the urologist here. I'm sorry, I missed your name.
So it's a tough one. Dan Wood.
Beautiful. Well, Dan, we're patients of the Colorado Clinic. I'm curious as to when you recommend the young men to come and see you. Before, when you see symptoms, what have you?
Can you hear me? Okay, great. So the answer is when Dr. Apcon tells us. You know Sue, I'm sure. And so we work very closely with Dr. Apcon, and whenever she wants us to see people, we will. If you have urology questions, then just ask her, and she can send you to see us, and we'll see you whenever. But she has a screening question group of about 5 or 6 questions that she'll probably ask you most times you see her. If anything flags up on there, then obviously that would be a trigger. But if you have questions and you want to come and see us, just ask. We'll happily see you.
So I probably don't know she's screening for that. So she's really good at asking those questions without raising flags in us. So that's been very, very helpful. And I want to applaud you for finding a way for these kiddos adult kiddos to find a way to talk to you guys privately. I think there are many times when parents don't realize that the kiddos need some privacy in those realms, and I encourage that a lot with my kiddo, but thank you for doing that.
Thank you.
Dan, for other places that don't have a Dr. Apcon to screen or whatever, can you actually give it some of the questions that she does ask to screen for others that might be like, hey, I never thought we might need to see a urologist?
So some of the things that I was highlighting in my talk, if you feel like you're going to the bathroom more frequently than you have done, as I say, that can be a manifestation of a number of things, but it may mean you're not emptying your bladder completely. So if you're going to the bathroom more frequently, if you feel like you're having to strain or push to empty your bladder, if you start to leak urine, then we'd want to see you. If you feel like you're getting other symptoms, so you start to develop urinary tract infections, we would love to see you. If you see other things that seem strange, you may see blood in your urine in extreme cases, then obviously we want to see you. Those are pretty obvious. But frequency, so going more often, starting to leak urine, feeling like you have to strain, would I think be the big ones.
What about quality of life, though, too? I mean, what you're talking about is more of like the physiological and medical issues, but for some of these young men who are trying to attend college or have a job and things like that, are there things you have to offer someone for quality of life, too, for like, you know, basically how do you urinate and what can we do to assist you to improve your independence?
So I like to have that conversation on an individual basis. As you say, you know, people want to do the stuff that they want to do. They want to go to college, they want to work, they want to be able to go out with friends and so on. And so there are lots of things that we have to offer or to talk about. We may talk about, in the first instance, medication to see whether we can help with emptying your bladder more effectively. That may make a big difference to you, and you may not need much more than that. Right through to sometimes bigger surgical operations to try and get your urine out of your body without you needing to catheterize or wear a catheter all the time. Some people will choose those more extreme options if they're the right things for them. Some people will be able to stick at the less interventional side of things. And then there's a range of stuff in between there. And we'll talk to you about the trade-offs, the good and the bad bits about those things to help you make those choices.
Very good. Any other? I have one. For Ashley, oh, wait a minute, anyone? Bueller?
Hi, thanks for the great talk. My son is 24, and we've talked a little bit about some problems he's been having with hemorrhoids. So we took him to a colorectal surgeon about 7 months ago. They had never examined a patient in a Hoyer lift, and we had to take our own lift with us to the appointment because it was outside. So I think we convinced him that they should have one in the office because he said he couldn't believe how easy the exam was. He was really fascinated by the Hoyer. But just one tip. He said my son wasn't nearly at the stage that we should consider a surgical intervention because you can imagine the complications with a non-ambulatory patient. But one thing he did recommend was stop long-term sitting on the toilet shower chair. And that one thing has kind of gotten rid of about 80% of the issue for us.
Yeah.
So dangle from the Hoyer. Who knew? But anyway, sorry, it's kind of a, but it is something I wanted to let people know because I would have never thought that. And talking through the whys and the physics of it all, he's just like, it's all about pressure and it's being on that chair too long. Try to minimize your time in the shower even. That seating position is not very good for that particular problem.
Very good.
So.
I have another practical question. As some of our children get older, they gain weight because of inactivity, and also urination may become problematic because there's retraction and difficulty in accessing their penis. What practical solutions would you have for families who are experiencing this to make it more comfortable for the individual that you're trying to help and the family member who is trying to care for them?
Do you mean in terms of the urination side of things?
Yeah, because in some situations, even an external catheter is impractical. Using a bottle urinal while you're trying to gain access, there's a number of complicating factors. And do you have experience in this, and how would you help a family solve that?
Sure. I mean, I think, you know, you're into a relatively complicated conversation there, but to kind of summarize, we think about whether or not there is any form of catheter management that might be practical for you. And I think sometimes we work with amazing specialist nurses who can spend time with you and look at how those options might work. Occasionally, we'll think about whether we need to think about an operative solution. So whether or not we would create a suprapubic catheter where the catheter comes out through the stomach, which makes it generally much easier to change than having to exchange a catheter through the penis. There are other more major surgical interventions that we can discuss if between us we think that's appropriate. But that's the kind of line of conversation that we might look at.
Okay.
There's also urinary bottles that are made more designed for women, that sometimes the males who have the issue of the retracted penis, that could be easier to access than if you used more of the male organized bottles.
All right, thank you.
And I think one of the things, the committee that we're looking at and things that people don't talk about a lot, you know, they talk about having to sit on the toilet a long time. We talk about like having to do things. So there is going to be a lot of talk about surgical interventions, because while it is scary, they've been very liberating and been able to help a lot with quality of life. But next question.
So we like to travel, and we go long distance, and our son's non-ambulatory, and now he can't do the 3-pivot trip transfer anymore to a toilet or whatever. So we are just looking for like ideas for like long distance travel to trying to facilitate like getting on that plane and worrying that he's gonna need that bathroom or something. And rather than him dehydrating himself before the trip, which he tends to try and do, and cutting back on spicy foods and all of that, is there like a magic pill? Is there some other thing that would help just for that travel period of time to facilitate for them the worries and anxiety?
I should have kept my mouth shut, because you are basically presenting the case that I talk about all the time.
Okay.
This is where actually surgical interventions can be very liberating and very increasing like being able to increase your activity and being able to not have to worry about getting in a car, riding for 2 hours, being on a plane isolated for 6 hours, 8 hours if you're going international. The suprapubic catheter, we've had a couple of patients in my clinic go that route, that basically it's a catheter that stays in, goes to a bag. Colostomies have been used a lot in people with spinal cord injuries, born with spinal defects, been around for years, but never been talked to with young men who have either muscular dystrophy or spinal SMA or other things too. We started implementing those at it's totally revolutionized some of these guys' life. One is, they used to want to always go to a baseball game in Cleveland, their choice, but they wanted to go see the Cleveland play, and they couldn't do it because of the same things you're talking about. Again, I know surgeries are scary to talk about, but some of these things, some of the simple things that we can do can liberate you so that you don't have to worry about getting to the bathroom, don't have to worry about...
But that's not going to affect bowel movements, right?
So a colostomy will allow you to basically not be at the mercy of having to have a bowel movement, can avoid having to sit long hours on a toilet. You change it once, twice a day. It is, you know, a bag on the outside, so people get kind of offended, but we shouldn't negate it, because like I said, a lot of guys are now being able to do things that they never thought they could do before because they can do it. If you're struggling to have a bowel movement, if you're thinking about having a bowel movement hours in a day, you take an hour to 2 hours out of the day to have a bowel movement, you're having stool accidents, you're constipated, you're having belly pain, a colostomy can take all those side effects and reduce it down to about an hour to 2 hours out of the week of managing your bowel movements.
Thank you.
So there's a couple of online questions that I'd like to pose to the group. And the first one is, what does red color of urine, or if urine color is deep red and maroon, indicate UTI and hematuria was ruled out. When should one do a cysteine test or meet a nephrologist?
So I think if the urine is, the question is if it's kind of a dark red color.
Yes.
So there are lots of things that can discolor urine. Obviously, you've mentioned that hematuria is ruled out. That sounds more like hematuria than anything, but I think a conversation with a urologist or a nephrologist sounds very appropriate at that time to thoroughly evaluate that. Yeah.
Did you have a, I'm sorry.
And I had one more quick question. The other person wanted to know when was it appropriate to consider a feeding tube for an individual with Duchenne?
Is this on? Okay.
Yep.
Fantastic question. And this kind of goes along with Kiera. I feel like this is a topic of conversation for both of us because it can be a swallowing difficulty or it can be just an inability to maintain weight. But I would say overall, if we're having unintentional weight loss and maybe not waiting quite as long as I feel like a lot of parents and providers are willing to do. If a young man has been carrying a lot of extra weight for some time and starts to lose it, people are less concerned, regardless of the fact that it is unintended. As soon as we start to see that unintentional weight loss or an inability to swallow safely, I think those two things are generally when we like to make the push toward a feeding tube. Also, it can reduce the amount of time that these boys are spending eating. If it becomes so labor intensive and they can't go out with their friends or they can't, have as much independence because they're spending so much time trying to get in their nutrition, a feeding tube is often a good option at that point as well.
Yeah, I was going to kind of piggyback on Kent's comment earlier. Oftentimes that quality of life piece, if we're spending hours a day thinking about feeding and, trying to get nutrition in and everything, then that's a time to consider it.
All right, one last question.
So I've got a 25-year-old son, and I think the doctors are recommending a GI tube. So in particular with the surgery and him being of that age and there being some issues putting under anesthesia, et cetera, would there be any good case for doing both a colostomy surgery port as well as a GI tube port at the same time?
That's actually, if we're deciding to do one of those in our early 20, mid 20-year-olds, we will discuss with them about doing the other at the exact same time too. Happens all the time because if you start giving more food now, you're going to have more bowel issues too, having to evacuate. So yes, we've done that in at least 3 or 4 patients in the last year.
And just any opportunity then for also for a port, for a catheter port as well, or not?
For blood access, you mean? Or suprapubic catheter you're talking about?
I would have the discussion, ask the question. Nothing wrong with doing that. And certainly, if there is a urology problem, then doing a combination procedure rather than having 3 separate GAs makes a huge amount of sense.
Yeah, because the thing is, you're exactly right. What I see a lot of families do is they're like, we'll make that decision later. But at that time, the heart continues to, degrade, the lungs, and then you get to a point where I had to tell a young man this past week he really wanted to have a colostomy, but if you undergo anesthesia, you may not get off the tube, and that was a no-go for them.
Yeah, that's the cardio and the pulmonary are the big concerns there.
So if you're wanting to think about those things, doing them at the same time under Warner GA is possible, yes. You just have to talk with your team. Everybody has to be on the same board, same page. All right. Thank you very much. We're a little bit over time, so my apologies to Rachel. I'll try to avoid her for the rest of the day. So, there she is. All right, thank you very much.